morning, good morning.
Good
Awesome.
morning.
Good morning.
Well, in the interest of time, I'm going to respect everyone. We'll just get started. So this is Dr. Maayan Leroy-Melamed. She is, as mentioned, an adolescent medicine specialist at Hasbro Children's at Brown University, and she's also the assistant professor at Warren Alpert's Medical School at Brown University. She was a Peace Corps volunteer in the DR, and she completed medical school at the Medical School for International Health at Ben-Gurion University before completing pediatric residency at UMass Bay State and a fellowship at Indiana University. She's interested in complex social, cultural, and medical intersections in sexual reproductive health. And I've had the pleasure of connecting with Dr. Leroy on a piece we ended up publishing in Lancet on reproductive justice in sickle cell, which essentially is calling for whole person care. So I will hand over the screen if you want to share your presentation. Today, we're going to be talking about contraceptives with regards to sickle cell and just some considerations that are necessary.
Okay, so I just want to make sure that I'm allocating time properly because I thought the case presentation was first. So I have like 20 minutes. I just want to not step on anybody's toe.
You're totally good. If you have, you can go
Okay.
up to 30
And since there are
minutes.
only like 3 of us here, do you guys mind introducing yourself and telling me like do you prescribe contraception? Like what is your sort of like lens? Because I have like I talk a little bit about like the research and a little bit about like contraceptive in general. I just want to make sure I'm knowing what to focus on, who I'm talking to.
So full disclosure, this is like my team who's on, I share the echo sessions with my team just because I think it's a good opportunity to expand knowledge and whatnot from a didactic standpoint. So usually we have kind of a good show from across the country. I have no idea what happened today. I don't know if there were some technical issues, maybe that people just thought it wasn't happening and left. I have no idea. So I apologize. But this is actually Ashley from Jefferson, who is a prescribing NP. And then I can let you ladies introduce yourself since you're on. Thank you so much for coming. So I mentioned Christina's patient navigator. So she helps kind of from just making sure that our patients don't have any barriers and helps be a liaison to make sure our patients get what they need. Monica is my dedicated sickle cell therapist, which I feel super fortunate to have, since I know it's not common in the sickle cell space to have a 100% FTE therapist. That's exciting. And then I have Vicky, who is my case manager and care coordinator, who we hired recently. Or time is flying. It's probably not even that recent anymore. So this I feel like is like a personal presentation to the Miami team. So thank you, Maayan.
Awesome. And okay, cool. All right, so I'll sort of breeze through everything, but I'll try to make it like as interactive as possible since you guys are, it's a small room. Okay, super. So I have not yet shared my slides, so that would be a good place to start. All right. Can you guys see them?
It's loading.
Okay. There we go.
Okay, you're up.
Can you see it? Okay. All right, super. All right, so I'm going to talk about contraception and sickle cell disease. So Maya gave me an excellent introduction. I'm an adolescent medicine doctor, which means that I finished my pediatrics residency and then spent an extra 3 years subspecializing in teenage issues like birth control and periods. So that's sort of where I'm coming from. And my purpose of the talk today will be, computer's being funny today. So I'm going to talk a little bit about reproductive justice and what it means for people with sickle cell disease and identify referral, recognize barriers to reproductive choices in sickle cell disease, identify referral pathways for prenatal and contraceptive care, assess common contraindications and side effects of specific contraceptive options, talk about the risks and benefits of injectable contraceptives, also known as depo-medroxyprogesterone acetate, or DMPA, or just Depo, in the context of sickle cell disease, and apply the best contraceptive options in consideration of sickle cell disease. So just to start with the reproductive justice framework, which was coined by Black women in the 90s, right? About the right to have a child, the right not to have a child, and the right to parent the children one has in safe and sustainable communities. And thinking about that in the context of intersectionality. So most people with sickle cell disease are Black and have had sort of experiences within the medical community that have been marginalizing, and within like their social world that are marginalizing, and also have a chronic disease, and which is complicated within the medical and outside of it. And then they are also usually women if they're seeking contraception, which makes their like their standing within a largely male dominated medical system often difficult. And there are also culturally responsive practices that are somewhat complicated within contraceptive care and sickle cell disease. These biases come together with the chronic disease, racism, and sexism. So I want to sort of acknowledge that in terms of the chronic disease bias, there's often like the like genetic transmitter sort of stereotype within the racism. There's like the welfare queen stereotype. In terms of sexism, there's a history of forced sterilization in these communities. There are higher levels of hysterectomies for bleeding during pregnancy, and denial of treatment for infertility, like very much now. And it goes back to when sickle cell disease was first identified. Linus Pauling discovered the hemoglobin S gene, essentially, and his suggestion was that people with sickle cell disease should get a forehead tattoo so that they knew not to marry other people with sickle cell disease, which hopefully we can all recognize is insane right now. But it's not that far from, I feel like, a lot of providers who just tell people don't get pregnant. So I think like we still have a ways to go, and hopefully we are all part of the solution. Any questions about reproductive justice before I talk more about like reproductive health in sickle cell disease? No? Okay. So while we want to maintain a reproductive justice lens, it is still a little bit complicated when we try and provide reproductive health care for sickle cell disease, because much like in other populations, over 50% of pregnancies are unintended. And by the time people with sickle cell disease are 21, up to 56% of them have become pregnant. And there are a lot of reasons for that. And then there's a 26 times greater than non-Black women risk of maternal and fetal morbidity and mortality in women with sickle cell disease because of thrombogenicity during pregnancy, and because of psychosocial factors, and because of us. And hydroxyurea is controversial, but considered to be a teratogenic medication by most people. And often people with sickle cell disease treat their hematologists as primary care providers, and they're the ones who would be prescribing birth control. So it makes it complicated who is evaluating for the need or the desire for birth control in people who do want it. So in my discussions with hematologists, a lot of times they feel like Depo is the answer to everything, because there were 2 studies showing that Depo improves anemia and sickle cell crises. But then 2 studies not related to sickle cell disease specifically showed an increased risk of venous thromboembolism with Depo. So that makes things a little bit more complicated. And then there are other concerns with Depo, like weight gain and bone mineral density, especially in teenagers, and then long-term return to, not long-term fertility, but medium-term return to fertility, because some studies show that Depo has up to a 1-year return to fertility, which is longer than any other reversible method. So Any questions about Depo?
I would just say your experience, because I feel like Depo, it really is the first go-to for a lot of the gynecologists for our patients. And
For
it
the
seems like break,
gynecologist too, that's interesting.
yeah, and breakthrough bleeding is the most common side effect. And I find that it can take a really long time for women to achieve amenorrhea or no period, that sometimes it seems like the breakthrough bleeding and trusting the process for 6+ months ends up triggering more sickle cell pain, that, and then just the long-term risks of Depo, just from a bone health standpoint. I still get surprised why it's the go-to or the first one, especially on the adult side.
Yes, I think some people like it. And like, I'm not knocking that at all. I like, my belief is that people should have a full spectrum of contraceptive choices, and if they want Depo and they like it, that's great. Personally, it's my least favorite form of birth control because I mostly treat teenagers and they hate the breakthrough bleeding. And it's the only method that I can give you and then not take away. Like, if you don't like it a couple weeks in, it's like tough. You just got to wait out the 3 months. So it's tough. Any other questions or comments about Depo? All right. So, if you ask what adolescents are using in particular in general, not with sickle cell disease, that most of them use the birth control pills, but then and then like Depo is a little bit farther down as to our point. Increasing amounts are using LARCs like the implant and the IUD. But so that begs the question, are pills the most appropriate thing for people with sickle cell disease? And I think that most people think no. For most people with sickle cell disease, I think it really needs to be a conversation with each patient. In general, pills increase the risk of venous thromboembolism by 3 to 4 times. So when I'm counseling people without sickle cell disease, their baseline risk of VTE is 1 in 1,000. So clinically, the difference between 1 in 1,000, 3 to 4,000 is not that big of a difference. But because sickle cell disease is considered an inherited thrombophilia, and by the time most people with sickle cell disease reach their 20s, a lot of them have had at least micro obstructions like micro strokes. I think that it is a little bit more complicated. In sickle cell disease, there was one study that showed that people with sickle cell disease, a third of them are still using birth control pills, even more than Depo. And then in that same study, they found an increase in venous thromboembolism in people with sickle cell disease with the patch, but not with pills. So, but and like, you're weighing that against the fact that if pills are the only type of birth control that they are interested in, it's better than the risk of VTE from pregnancy itself if they're not interested in becoming pregnant, because it's like 10 times more of a risk than pills themselves. And then there are also other benefits to birth control pills. They can sort of control it, taking them every day, and there are acne benefits to them. So if you are talking to an individual patient who doesn't particularly have a risk of VTE, like they have relatively mild disease, they're younger, they have no other complications, they have no signs of stroke, then like, it might be a conversation that some people have, keeping in mind that sickle disease is an inherited thrombophilia, as most experts considering it. So, meaning like most people with sickle cell disease are at increased risk of clot, and you need to have a conversation about this increasing their rate further. So the resource that I think is most helpful to look at for people with sickle cell disease or in general is the Centers for Disease Control medical eligibility criteria. So if you just Google CDC MEC, it'll come up. It was updated last year, sorry. There are little evidence on any method specific to sickle cell disease. They're working on publishing the literature reviews that were part of the recommendations, and most of them aren't published yet. But Combined hormonal contraceptives, so pills, patches, and rings containing estrogen, is listed as category 4. Category 4 is considered an unacceptable health risk. So until this last recommendation, the CDC indicated that the benefits outweigh the risk. And so it's sort of a like evolving conversation. And like I mentioned, Medicaid data is showing that girls are using it, especially younger people who are less at risk of clot, but it's still a concern. So these are how the CDC lists the risk. One is that the advantages greatly outweigh the risks. 2 is advantages generally outweigh the theoretical or proven risk. 3 is a theoretical or proven risk usually outweigh the advantages. And so Depo was categorized as 2/3. They couldn't decide between 2 and 3. From what I can understand, the risk of venous thromboembolism or osteoporosis risk versus the benefits is unclear. And I think that also depends on the age of the patient and on their baseline risk of osteoporosis and their family history. And also, an important thing to mention is that the CDC medical eligibility criteria is for pregnancy prevention. So this risk is always sort of weighed against the risk of pregnancy itself. So if someone's not planning on having sex and not at risk of pregnancy, and they're using it for menstrual management, which is an important consideration as well, there are a lot of consequences for menstrual management. A lot of people have increased crises and a lot of pain from menses every month, but the weight of that consideration is different than the weight of the risk of venous thromboembolism in pregnancy. So again, each patient is different, and it's sort of a nuanced conversation that each person needs to consider. So any questions about the medical eligibility criteria?
Did that updated information change your prescribing practices?
No, because I think it was delayed from expert opinion, which because of like the research I do, I like talked to a lot of hematologists that like told me their expert opinion. And I think the CDC is more reflective of like expert opinion. I think it's like large sickle cell centers were already following the recommendations. I think the recommendations sort of were reflective of what large sickle cell centers were already doing. It's just like not every person has access to a large sickle cell center, and that's why it's really helpful to have those recommendations be accessible.
Sure.
Does that make sense? So sort of you set me up nicely for the next point, is that like it did it not just change what I was doing, did it change what anybody else was doing? And if you look at more recent data, so Andrea Rowe published this study out of her center in Philadelphia, and it was looking at what people are actually using. And the IUD is much more popular now. It is catching up with Depo. Depo is still the most popular. Well, next to none. So considering that also that a lot of these adults that she studied are sexually active, so that's important to think about. There is a really high rate still of tubal ligation and permanent sterilization or permanent contraception for people with sickle cell disease, higher than other parts of the population, which I think is an interesting discussion. And then OCPs are also pretty popular, but not as popular as people without sickle cell disease. And then the implant, not super popular, patch, and other methods are less popular. So I was interested also in knowing what you think about different types of contraception and how they are prescribed birth control. So I and in general, like when I talk to youth, I think that they're very overwhelmed by the different types of birth control. So it's sort of like looking at the cereal aisle. It's like, I don't know what really is the difference between like Golden Grahams and Honey Nut Cheerios. Like, is one of them better for me? I don't know. Like, I'm not really sure. So, and I think the way we present it can be really confusing. But in the 12 people that I surveyed in Indiana during fellowship right before COVID, 3 were prescribed birth control, 2 for menstrual suppression. One of those was Depo, and one of them was the implant, which was that person was also sexually active. And then one person had the implant just for pregnancy prevention, not for menstrual symptoms. One person did report sexual activity with no birth control. So I think this like validated my reason to keep on studying this. And then, so I'm doing qualitative interviews now of people with sickle cell disease to ask them more about their reproductive health conversations and prescription patterns and stuff like that, and what their experiences have been with contraception. Before I did that, I surveyed providers from the ASFO listserv. So, Maayan, I don't know if you participated in that study, but hopefully you did. Or anybody else on this call, but it had a 30% response rate, which is pretty difficult for surveys of providers, 77 pediatric, 12 adult, and 1 combined. We asked them about how important they think sexual and reproductive health is. Should the conversations be standardized for everybody at sickle cell care centers, and which of the discussions should be should include parents, and do you have a preferred method of contraception for pregnancy prevention? So the results showed regarding acceptable methods that most of them did not think that combined hormonal contraceptives, so pills, were acceptable. 38% thought that they were acceptable. 22% said the patch was acceptable, and 33% thought that the ring was acceptable. And there was no difference between adult and pediatric providers. And then I asked it in a different way, whether it should never be used. And a minority of them agreed with that statement. So I think people are sort of confused about it, or they understand that there's nuance to it. So it's definitely a complicated discussion. I think most people certainly agree that pregnancy is high risk in people with sickle cell disease. Any questions about this data? So then I was curious because there seemed like there was a lot of nuance in those responses. So I did qualitative interviews of providers, and I found some interesting themes about like decision making and weighing like fertility versus crises versus dysmenorrhea, and how comfortable they felt with prescribing contraception. And I think that nobody expects hematologists to become like full spectrum contraception providers, but understanding more about it and like being able to counsel their patients seemed to be something that everyone agreed was important. I tend to steer away from estrogen if we can, but I also remind them pregnancy is a higher clot risk than really all birth control pills. And these were the key themes around it. So then the question is like, what should providers do? So what I typically do is my first question is, would you like to become pregnant in the last year? And if that's from a study and a campaign called One Key Question. If they are interested in becoming pregnant in the last year, my recommendation is to consider an MFM referral. Because I think that I think planning and discussing is very important to have with an expert who can tell them like what medications they should be on, what medication they consider switching, and working with their hematologist in an interdisciplinary way. I think everyone is appreciative of. And then if they're not interested in becoming pregnant in the next year, it depends on the patient. So ignore this QR code. I apologize. This is for a larger group. And we can just sort of like unmute and raise hands and stuff. So does somebody, so actually, do you want me to go through cases, or do you want, because I'm not sure how much more time you want me to keep talking. Is there
I mean, we could
interesting?
do up to like 5 more minutes, and then Ashley, are you going to need a full for your case?
Nope.
No. So we can try to wrap up in like the next 5 minutes, and then we'll be able to end with the case.
Okay, super. So
I
I'll
love the
skip this
cartoon.
case, but the TLDR is she has migraines with aura. And so that migraines with aura is a contraindication for estrogen. And this particular patient was not interested in taking a pill every day and was very interested in high effectiveness reversible methods. So LARCs would be a good conversation to have. Long-acting reversible contraceptives include IUDs and implants. They're the most effective method. They're more effective than getting your tubes tied, and they're safer. They're rare contraindications, not usually involving sickle cell disease. They have the highest patient satisfaction compared to short-acting. They last 3 to 12 years. They have a rapid return to fertility. They're the most cost protective. They're least likely to be used for teens because I find that teens are less likely to be interested in a procedure, which I think is totally fair. Any questions on these methods?
Why do you think it's like, do you think for teens and younger individuals, it's just the insertion process, or just maybe they're more sexually active, or what do you think it's reserved more for the older adults?
I don't think it's reserved more to the older adults. I think part of it is that there's a little bit of a provider bias. The CDC medical eligibility criteria used to not recommend the IUDs, for example, to nulliparous women. And there's a lot of like cultural, like historical baggage around it. So like the current IUDs are very different from the IUDs that were on the market in like the 70s, for example. So like the Dalcon Shield, which was on the market in the 70s, got removed because it caused PID and infertility. And I think there's like a lot of like the moms are like, no, you can't get an IUD because you'll like never be able to have babies, and like you're too young to like make that decision. There's just like a lot that goes into it, I think.
Makes sense.
In terms of Nexplanon, it's also a newer sort of, relatively speaking, method. It is more popular in the IUD in young people, mostly because I think that like young people tend to not be as comfortable with like other people touching their vagina for a procedure or for any other reason. And I think, and it just seems more permanent to like have that procedure being done, I think, even though it is reversible. Oh, sorry. Did someone ask something? No. So there are technically 5 types of IUDs. One of them is the copper IUD, which I'll talk about next. But the IUDs last up to 8 years actually, and require a doctor visit for removal, or it's recommended. That's a whole other discussion. Most will cause irregular bleeding initially, but will make periods lighter, and about 20 to 30% of people with the highest dose of levonorgestrel have amenorrhea after the first year. So those have like the most beneficial period pattern. It's also approved for like heavy menstrual bleeding acutely as well. The copper IUD makes periods worse and more painful. It does last up to 12 years. It has no hormones in it, no increased risk of VTE. So if someone does not have any menstrual complaints, then it could be a good method for them because it's very reversible, very effective. And just to review that the progestins increase the risk of VTE by 0.1%. So the estrogen in the combined methods is really what we're worried about for the aura for risk of VTE. In the rare cases that you're really worried about VTE, even that 0.1% increase is a risk. That's when the copper IUD could be helpful. But I think that like experts agree that the progestin only methods, particularly the Nexplanon and the IUD, are such a low dose of progestin, and progestin itself increases the risk of VTE so little that it's not really significant. The Nexplanon can last up to 5 years. The main issue with it is that it causes irregular menses at the beginning. So I always counsel patients that if they don't want to wear a panty liner for the foreseeable future, then we should talk about other methods. And then I think we've talked a lot about combined methods, but combined hormonal contraception, like the pills, usually contains both estrogen and progestins. So does the patch and the ring. There are also progestin-only pills that won't increase the risk. This is just going over a little bit that most people with sickle cell disease do have menstrual concerns, including over half who have dysmenorrhea, higher than the general population. And then we're still sort of researching how different types of hormonal treatments can help. But in the general population, any hormonal birth control will improve dysmenorrhea. So in conclusion, people with sickle cell disease deserve individualized contraception, considering historical trauma, interaction with their disease process, increased menstrual concerns, perinatal risks, healthcare limitations and connections, and individual needs and desires. And thank you. And if you know of any patients who are interested in participating in my qualitative study, please pass this flyer along to them. I'm happy to send you the flyer, or you can just send the link with the QR code to the red cap for me to contact them. And then on the left-hand side is a QR code just to give feedback about my presentation, because we're all trying to improve.
And if you want to email us this flyer, we'll be able to forward
yes,
it.
I would love to. Thank you.
Does anybody have any questions?
Yeah, please let me know what questions you have.
This was a good update.
No, this was
Thank
great.
you.
I was maybe not a question, maybe just kind of like a statement. I find in practice now, with like Nexplanon specifically in patients that are on iron chelation, that also like adds to the conversation of like effectiveness, especially for patients that are on Depo and also on Nexplanon. So I feel like sometimes like I do primarily the hematological work as a nurse practitioner. So I see it from that lens, but I feel like it's just sometimes when talking to patients, it's just so complicated with all of like their other medications that they're on and their comorbid conditions. So it was just, this was really helpful to kind of see what other people are doing. And
wait, so tell me more about the iron chelation and Nexplanon.
so we have this amazing pharmacist that works with our team here at Jefferson, and looking at it, it looks like Depo actually reduces the effectiveness of Nexplanon, and so making us kind of have to make a decision on like using other therapies for iron chelation that maybe are like not the most easily taken by patients.
Is this just because it's a CYP3A inducer or something that could potentially?
Yeah.
Is this the same pharmacist who taught us the interaction between oxycodone and
Yes.
Jade as well, which like it was foreign to everybody?
Oxycodone
Yes.
and what?
So
And
there potentially is another interaction between Jade essentially and oxycodone because it uses the CYP3A pathways. And our pharmacist was not actually in agreement towards it. So after his, I'll forward you his response. But it is interesting and something that should be discussed until we have more data to confirm whether or not
Yeah, I'm
the logic makes sense.
curious. I don't know if there's been a lot of studies. There are some studies about Nexplanon and some other things that like have to do with like the CYP, they're inducers, I think. The main one is mycophenolate, the one that's used for narcolepsy. So I had a patient so Nexplanon doesn't go through first pass because it's a implant. So it's less of a concern than things like pills and pills. And less of a concern than estrogen, because estrogen has more of a interaction with the CYP 450. So when I was researching for a patient who was on mycophenolate, it seemed like there wasn't enough data to support that. I definitely would like to look into iron chelation, because I feel like that's sort of common in our patients. And then for this patient, we ended up choosing the Nexplanon because she definitely didn't want an IUD, and was willing to take the risk that the Nexplanon would be slightly less effective, but like wasn't really clear how much less effective, if at all.
I guess like it sort of depends on like your purpose of using the method. Like if it's for purely like menstrual suppression, I guess, or birth control. And I guess if you're also using it for birth control, just, I mean, do you counsel people like on barrier methods also?
Yes.
Like this
Yeah. I say
is my idea.
like we don't know how much less effective it is because of this other medication you're on. I would strongly recommend using condoms. And my recommendation would probably be using like an IUD would make it more effective, but I'm certainly not going around telling people they have to use an IUD or nothing, you know?
Interesting.
Yeah. Thanks,
Just
y'all.
goes to show everything is individual when it comes to sickle cell, and we cannot, it's not cookie cutter, everyone. We have to take into a patient and all of their priorities and adherence to pills and history and symptoms when we're coming up with the best course and contraceptive for them. Awesome. Thank you so much. That was really informative. And again,
Thanks,
don't
guys.
forget to email the flyer. We're happy to help and hopefully
Yes,
get more
I'll send it right in.
participation from you.
Thanks.
So for the latter half of this, we're now going to switch over to Ashley, who's going to present a case on this 22-year-old man with hemoglobin SC.
Yep. So this is a 22-year-old who recently just transitioned to our team with SC disease, who actually is not currently admitted, but had several, mainly just ED and OBS visits, over the last really like 6 to 12 months, but in the last month of September, has had increasing utilization. So about 18 visits between ED, OBS, and the infusion clinic in September. In the admissions, if he's had, they've all been OBS and like not any greater than a day. And he hasn't had an inpatient admission that's lasted longer than a day in a couple of years. His average utilization, it looks like over the last 6 months or so, has been 6 to 8 times. And those were mainly in the pediatric hospital until he transitioned his care to us. Dr. Lanskrantz is hematologist. Dr. Mayer is his primary care. Has some lower back pain on presentation with these events, but reports not having chronic everyday pain, and is not on a long-acting opioid. He is on oxycodone 5 milligrams. He was prescribed 15 tablets a week, but then was running out early. And his last prescription, which was given last week, was for 30 tablets. He's actually scheduled to see me for the first time. I've never met him before. He's met other members of my team. I'll see him today in clinic. His outpatient medications include Levelox, Max, which was recently started by Dr. Ferry, our psychiatrist, for OCD-related symptoms, on oxycodone, acetaminophen, Wellbutrin, which he's been on even since through pediatrics. And he's actually on 300 milligrams of Wellbutrin per day. He's on gabapentin, and he's on Seroquel daily. When he comes in, he gets 6 milligrams of IV push morphine, and for the first dose, and then his subsequent doses are 4 milligrams every hour. He sometimes goes on a morphine PCA, but sometimes after 3 dosages, he's able to go home. You can scroll down a little bit. Yep. Can you scroll down for me? He is usually like on a bowel regimen at home, and then also while he's in the ED. He had 1 episode of acute chest syndrome in 2022, has not had a stroke, PE, or DVT, has not had cardiomyopathy, pulmonary hypertension, or renal disease. He does not have iron overload, has a history of osteomyelitis, and has documented avascular necrosis to his shoulders and hips that did not require any surgical intervention at this time. Does not have a history. It does not currently have depression. It looks like up until 2021, they were calling this major depressive disorder, but then he had a hypomanic episode, and they changed his diagnosis in 2021 to bipolar 2 disorder. No history of substance use disorder or aberrant opioid usage. He's been following with the pediatric team with psychology and psychiatry, and now has transitioned over to our psychiatrist here. It sounds like he's been having, in addition to the bipolar disorder, some what they're calling sort of working diagnosis of anxiety disorder, and now with some OCD features. And so they've been making some adjustments to his medications, but he has sort of fully transitioned from the psychiatry standpoint to our psychiatrist, and is still seeing behavioral health in peds, but will slowly see our behavioral health. He's not on hydroxyurea. He previously was on hydroxyurea and did not show any improvement in painful episodes. He tried Adakveo or crizanlizumab, and his pain actually worsened. When he met our hematologist here, they discussed chronic exchange transfusions, and the plan is actually for him today to have his first exchange. He does have red cell antibody to anti-S. He has an active sample in the blood bank. His last blood transfusion actually was when he had acute chest in 2022, and he's had a total of 5 lifetime transfusions. His vital signs are relatively stable. Heart rate was 71, blood pressure 128/84, temp was normal. He was 98% on room air. His baseline hemoglobin is about 12, and his most recent CBC, his hemoglobin was 12, and hematocrit was 34.7. White count was 13,000, neutrophil count was 9.6, MCV 79, platelets of 439, and an absolute retic of 164. That is not his correct hemoglobin electrophoresis. I think that I don't know where that came from. He has
We'll throw in a
SC
C there.
he has SC disease. That was maybe leftover. Yeah, so that is not his hemoglobin electrophoresis. His creatinine is 0.9. His total bili is 0.9. Has not had a urine toxicology screen, and no other additional laboratory or imaging findings that are significant. He is in college. He's a student. He's living on campus. He has Keystone First Insurance, his own insurance, which is a Medicaid plan, no transportation issues. He's a very highly functional guy. He's actually, I think, now in graduate school doing public health. And in between sort of these sort of acute episodes, like he will go and take his exams, and then he will come back. And so I think some of this is like he not taking his pain medication on a regular basis, coming into the ER, getting medication, and then sort of going back after he's done his everyday life. So the question that I have is, right, he has a lot of acute care utilization. He's saying he's not having chronic pain, but he does have evidence of avascular necrosis and, right, having frequent episodes that, right, could be chronic versus acute on chronic pain. We're trying to move him to exchange transfusions. Hopefully that will happen today. But I guess the question is like, should we change his treatment plan? When should we change his treatment plan? For the emergency room, should we wait until the patient gets exchanged, and sort of what other people's thoughts and strategies have been around patients with acute on chronic pain?
So for the pain, I know you mentioned it was back pain. Is that here? And he has AVN as well, but does he have, where's the chronic? Is it to his back typically, or that's just this current episode?
This was this current episode.
And
So
where
he
is his
doesn't,
pain typically?
so he
Or it
doesn't,
varies?
yeah, it varies. So like can be shoulder, it can be back. It's like he doesn't report that he has everyday pain.
Okay. So the main reason is just the healthcare for putting him on the red cell exchanges is just to reduce the healthcare utilization, since from a medication management standpoint, he hasn't really been able to benefit from anything. And the hydroxyurea, how long ago did he use it?
That was in pediatrics.
'Cause, yeah, I mean, you're starting the exchanges, so we're not going to go back to hydroxyurea. It seems like since you're starting the exchange today, it would make sense more. Sorry if I'm making everybody dizzy going back and forth for my own viewing pleasure. But it seems like if he were to get admitted and he just got exchanged within the 2 weeks prior, it's more of like a chronic pain syndrome than necessarily an acute crisis. And this is just challenging since it requires a lot of education, and there's still some wiggle room, I think, from getting creative from a pain management standpoint, to ideally try to keep him out of the hospital. But I think since you're meeting him today, you can have the discussion of like what red cell exchanges do and what the expectation would be and what it would look like if he were to develop pain shortly after, and how it might not necessarily be sickle cell pain and could be something else, just so you have realistic expectations from a pain management standpoint. But since it's also a new patient to you, you have to work on getting trust from him. So you don't want to come in and change his entire regimen at your first visit, which could potentially push him away from you. So for the first visit, I would kind of go over it and just establish trust and see what his goals are, and then talk about what the plan is with the exchanges to have a realistic understanding of what the expectation would be. And then maybe at the next visit, we can say, we'll reevaluate your pain and see what changes after this exchange, and come up with a treatment plan. But I think if it's your first visit with him, I always get mindful not doing too much or changing too much, just to prevent uneasiness on their end.
So, and I don't know what your approach is to this, Maya, but I think too, figuring out what's also happening. Like he's a highly
He's in
functional
school too.
guy. He's in school, so like maybe, right? And this is right, all hypothesis, right? Like I have to meet him and sort of see what's going on, but I don't know how the medications make him feel. Like, how does he take them? Like, if they make him drowsy and he can't function at school. So sort of all of those like pieces of like what's going on sort of in the everyday life. And
And
it's
how is
also,
school going too?
yeah,
Like
and
we have a patient right now who's dealing with bullying in college, which has been really challenging. And like even the school dean isn't letting her parents advocate because she's an adult. So having to give documentation. So I think there could be a component of school and just college beyond just the medication that could be adding another level of stress. But I think going in and pointing out and just making certain observations and asking those questions, I think instills trust with the patients, because it shows that we care more than just treating a lab number and a diagnosis, essentially. And then making sure that they have accommodations available just to reduce the impact of school triggering potential pain. I'm like queen of resources. I love to be able to help our patients kind of contribute to
yeah,
and
I
just
think
do what
also
we
too
want.
for 22-year-olds, it's so hard, right? Like they haven't had chronic pain, and then this might be right. They're sort of the changing of what's happening in their life and having more regular pain that might be more chronic, even if it's not every day, right? Like it can just be most days, right? Like I think we have this perception that chronic pain has to be every single day. And so if he's having it most days of the week, it still could be chronic. And so, but still trying to tease that out, acute versus chronic, especially with somebody with sickle cell disease is so challenging.
Very. Does anybody else have any thoughts or comments or feedback? You guys can go off mute. We're non-threatening. Even from like a mental health standpoint, if anybody has any thoughts or feedback or cool. Yeah, I think his age, he's obviously going through a transition from college, and I think he's going from minimal pain to all of that. I would just get on his level and make the observation with him. And a lot of times our observations, it might be so obvious, but to the person living it, they're just trying to get through the next day and don't necessarily realize that school is probably adding a lot of stress, and he's trying to figure out how to navigate and transition that. I would try and see, what does he think is triggering his pain? Does he have anything identifiable or not? Those who get triggered crises with no triggers, my own hypothesis, it's like a subconscious trigger of just the nervous system is activating to some subconscious threat, in which case there could be benefit from speaking to a therapist beyond just medication management from a psychiatry standpoint. We'll take it from there. But I think you can help this patient. And I would say optimistic, starting him on the exchanges and really converting him to sickle cell trait. And there's no reason for him to not benefit from this, that I would go in optimistic and with the expected outcome of reducing pain. But if not, like we still have so many other options. It's not like you've exhausted all costs, that I would just continue to reassure him and let him know that you have not given up, and we'll find what works for him.
I have a
Vicky, I
question.
see-
I have a question. Hi, my name is Vicky. I'm the case manager for Maya's team. For this patient, is his issue of hydroxyurea just a non-compliance, or is there something in his health that's affecting him taking hydroxyurea?
It sounds like he was fairly adherent to taking it. It was just that he did not show a reduction in painful episodes. And so like there isn't a whole lot. I mean, there's more data now than there was even a couple of years ago in using hydroxyurea for patients with SC disease. Right, there was that ASH, I think it was a panel or a poster presentation that happened last year that looked at patients and showing some benefit with SC disease. In my personal sort of anecdotal experience, it's sort of been a coin toss, right? Or coin toss. Oh my goodness, this morning. Thank you. Unlike whether or not someone with SC disease has benefited from it or not. And so it's hard. It's really hard for people with SC disease because we don't have a whole lot of options for any of our patients. For patients with SC disease, it's even more challenging.
Very true. Vicky, that's a good point. Let me talk to you offline about SC and hydroxyurea too. I don't think we've dived into that. Awesome. Well, I think this was an interesting case, and I think again just highlights how, going off with Maayan, there's no one size fits all when it comes to sickle cell. And we really do need to kind of turn every rock and try to go beyond just sickle cell. We really need to focus on the whole person, mind, body, and soul, and see how we can just bring the best health outcomes for our patients. So it's 10:01. If you look in the link in the chat, there's a link to claim your CME credits and whatnot. Thank you guys for participating. Maayan, thank you so much for your presentation. I always say if I walked away learning one new thing, then it's a success, and I learned more than one thing. So thank you very much. I really appreciate it.
Thank you very much. Yeah, let me know if you guys have any questions going forward. Feel free to email.
Awesome. So I hope everybody has a wonderful rest of your week. Happy Tuesday, and talk to you guys later.
Thank you.